Support for UWTV is provided by the Boeing Employees Credit Union. Good one.
Imagine not being able to walk downstairs, work in your yard, or even sit at your computer without suffering agonizing knee pain. The knee joint is a vital part of the anatomy. It's the largest joint in the body and one of the most injured body parts. It's estimated that 1/3 of all medical visits in the United States come from people seeking treatment for a knee injury. Some of the most common reasons for knee pain are swollen or torn ligaments, runner's knee, and meniscus tears. Having the injury diagnosed by a physician is the first step toward proper treatment and recovery.
If there's a significant trauma or a fall, we're going to worry about a fracture. If it's an overuse injury that's in the front of the knee, it may relate to a tendon. For a meniscus, usually the athlete experiences pain along the joint line, either on the inside or the outside of the knee, and it's associated with swelling, with clicking, with potentially locking, and the knee can't move in its full range of motion. That is definitely a reason to get in and get evaluated.
Some people know right away that they have a meniscus tear. Other people just complain of pain in the knee.
The meniscus is cartilage located between the femur and the tibia, which forms the knee joint. The meniscus is a rubbery, C-shaped disc that cushions the knee like a shock absorber. Each knee has two menisci, one at the outer edge of the knee and one at the inner edge.
This is a model of the knee, and looking from the front, if we pull down the patella and patellar tendon, you can see the end of the femur and the smooth gliding surface cartilage. Then in between the bones, the meniscus, there's one on the inner side and outer side of the knee. The meniscus are on the top of the shin bone and help the two bones fit together better.
There's a variety of ways you can hurt your meniscus. The typical way of injuring it involves a flexion, compression, rotation kind of movement. So what that translates to is somebody who's running and turns or pivots or cuts and twists, and that puts pressure on the meniscus and leads to a subsequent tear.
Meniscus injuries can be treated both surgically and non-surgically, depending on the extent of the injury.
Good. How are you doing?
Hi, good to see you.
Good to see you. Have a seat.
Thanks.
So how are things?
Things are pretty good. I've been biking to work and such. The last week I started biking.
Okay.
And it felt pretty good.
Now, how much
Andrew Etringer was referred to Dr. Krabak after injuring his knee while telemark skiing.
I knew something bad had happened from the pop that I felt, and I hadn't really experienced a knee injury before. So I knew there was something that I damaged something in there.
How about up through here?
Andrew had some ligament damage and an injury to his meniscus. Dr. Krabak gave him a brace to wear for stability, plus exercises to strengthen the knee area. Now, 1 month after his first appointment, Andrew is showing steady improvement. He's back riding his bike to work, an 11-mile round trip.
My range of motion's a little bit better, but when I pull it all the way up,
it still kind of hurts a little bit.
Hurts.
Okay, so not unexpected. It's going to slowly continue to get better. And as we know, you have your kind of ligament involvement in there, but tweak that meniscus as well. And that's all calming down, so that's great. That's moving in the right direction.
It's great visiting Dr. Krabak because him and I have a similar lifestyle as far as activities, and it's great to have him understand what I'm going through.
So the good news is that you're doing quite well overall. Sounds like
Andrew's meniscus was bruised, not torn, and his injury will most likely not need surgery. Dr. Krabak's prognosis is that 1 more month of physical therapy will enable Andrew to return to his active lifestyle. For other athletes, it may be a different story. Meniscus tears commonly occur during sports when the knee is twisted while it's partially flexed and the foot is firmly planted on the ground. These tears are also common in people older than 40 whose menisci are worn down. The meniscus on the side closest to the opposite knee, medial, is torn more frequently, and men injure their meniscus more often than women.
Meniscus tears are common in athletes who change directions quickly, so soccer players, tennis players, football, most everything that is played on a court or a field or that you do standing up, there's a potential for meniscus tear.
Adam Rogers is a work-at-home dad with a passion for tennis. He serves as a school program coordinator for the United States Tennis Association in the Pacific Northwest.
I work with PE teachers, athletic directors, students, parent volunteers, basically trying to put together after-school tennis options for kids so that they're not going home from school and doing this with their thumbs all afternoon. Here we go. Backhand, forehand.
Adam competes in tennis tournaments himself.
Here we go.
In March 2008, he tore his meniscus while competing in a national tennis tournament.
Felt a pretty strong pop in my knee, took a 10-minute break, popped a couple Advil, and got back into the match. Finished the match, played 5 more matches, and decided after match number 5 that there might be a problem and it would be time to go have this looked at.
Adam was referred by his primary physician to the UW Sports Medicine Clinic to assess the severity of his injury. An MRI confirmed he had an acute meniscus tear. An acute tear is a severe tear and associated with a specific trauma among active people, most commonly a twisting injury. That's what happened to Adam.
I'd had ankle injuries, I've had hamstring issues, back issues, but never a knee problem. It was a complete surprise to me to tear up my meniscus. I guess just the physics of a 200-pound man going that direction, trying to jump and twist for a ball over in this direction, and coming down on one foot while going full speed is just not conducive to proper knee health. But when it happened, it was pretty obvious that it happened.
Meniscus tears are categorized as minor, moderate, or severe. With a minor tear, there may be slight pain and swelling. This usually dissipates in 2 or 3 weeks. A moderate tear causes pain at the side or in the center of the knee. It may still be possible to walk, but swelling will increase over 2 to 3 days and the knee will feel stiff. There may be sharp pain when twisting or squatting. The pain may diminish over a couple of weeks, but will continue to come and go for months or years if left untreated. In severe tears, pieces of the torn meniscus may move into the joint space. The knee may catch, pop, or lock, and it may not be possible to straighten the knee.
Just have you go up and
A
down.
physical exam is necessary to properly diagnose the severity of the injury.
Like
The
that.
physician will check for tenderness, range of motion, and stability of the knee.
I kind of do that a little more. Is it? No, it's not so much. Physicians who specialize in sports medicine often are the first ones to evaluate a patient with the symptoms of a meniscus tear. They will typically get some x-rays, maybe an MRI.
Within the 3 categories of meniscus tears, the types of tears vary greatly between vertical, horizontal, or a combination of the 2.
Sometimes it tears what's called longitudinal along the kind of semicircular length of it, and it can tear in a horizontal or kind of sideways plane or vertical up and down plane. And then there's a radial tear, which is going across the meniscus itself.
Whether a torn meniscus can heal by itself is determined by the location of the tear. Tears on the outer edge, or red zone, tend to heal well because there's a good blood supply. Tears located on the inner area, or white zone, lack a good blood supply and therefore do not heal well.
There's a variety of things that could present similar to a meniscal tear. There's ligaments on the inside and the outside of the knee. The medial collateral ligament is a ligament on the inside of the knee that actually is intimately connected to the meniscus. So sometimes people tear that ligament, but not necessarily the meniscus.
If a meniscus tear is confirmed, treatment depends on the size, type, and location of the tear. A patient's age, health status, and activity level are also taken into consideration.
When somebody comes in with a meniscal tear, there's a variety of ways to treat that individual based on their symptoms. Sometimes we'll experience a meniscal tear because it's degenerative, it's getting older. It may cause a little bit of symptoms in regards to the locking or the swelling and pain in the joint.
In most cases, the first treatment option would be non-surgical.
The main thing is to get the inflammation down and get the swelling down. So we may use anti-inflammatory medications, which helps with inflammation as well as pain. We'll utilize such things as compression and ice to decrease the fluid in the knee and allow the pain and swelling to resolve.
While rest is critical to the healing process, it's also important not to let the muscles atrophy, as that can lead to subsequent injury. So non-surgical treatment also focuses on restoring range of motion and strengthening the knee, the thigh, and the hamstring muscles. This regimen allows patients to return to their regular activities as quickly as possible.
Okay, volley, good, overhead.
However, non-surgical treatment was not the remedy for Adam. His meniscus tear was a medial meniscus tear located on the inner edge.
Good job.
The torn loose meniscus in his knee was causing constant pain, popping, and locking. So surgery was his only option to repair the knee.
Okay, if your knees are bent, then you can punch it, okay? The most simple things were becoming very stressful, and you were aware of this injury. I mean, even sitting upright at a computer, working at a keyboard, I mean, just the weight of your lower leg pulling on the knee. Most of us were never even aware that there was actually weight from the lower leg pulling on it until I'd had this meniscus injury, and I could feel that dull ache just sitting here. Walking down a flight of stairs. I mean, something as simple as walking down a flight of stairs in the morning. I had to slide on my behind down the stairs.
Typically, with a severe meniscus tear, fragments of the torn piece begin to move in an abnormal fashion inside the joint. Because the space between the bones is very small, the mobile piece of meniscus tissue can become caught between the bone joint, causing great pain.
Anything on the red is out.
Dr. Green discussed possible treatment options which would allow Adam to return to competitive tennis as soon as possible. They decided on a minimally invasive arthroscopic outpatient procedure because it offers a shorter recovery period than an open incision.
Oh, nice hands. Nice hands.
Arthroscopy is a procedure used to examine and repair the inside of the knee by inserting a thin tube containing a camera and light through small incisions near the knee joint. With arthroscopy, the surgeon can directly view and repair the torn meniscus without an open incision.
Originally, the surgery when you had a meniscus tear was to do an open incision and remove the entire meniscus. Now we can do arthroscopic surgery, and instead of removing the entire meniscus, we found that it's much better to leave as much normal meniscus is seeming to function as we can, and so now we only take out the meniscus that is torn.
The reason it's important to leave as much meniscus as possible is because removing the entire meniscus can lead to early arthritis. Arthroscopic surgery is the preferred procedure for patients like Adam who want to return to their active lifestyle and play pain-free for as long as possible.
These are people that understand what sports injuries are all about. They understand the sports psyche, if you will, and that how important it was going to be for me to get back out there, in a timely manner and start competing. Their biggest challenge that it was going to be keeping the reins tight enough on me so that I wasn't getting out there 2 weeks after the injury and doing something really stupid, which I would be known to do.
In April 2008, Dr. Green performed a partial meniscectomy, removing the torn section of Adam's meniscus and leaving the uninjured part in place.
Okay, so now I'm ready. The surgery is done typically under general anesthetic, so you go to sleep, and it's a pretty brief operation lasting typically less than 1 hour.
Yeah, the day of surgery was a big reality check. I've broken bones, I've torn muscles, but never have had to actually go into the operating room and have something repaired. Everything has just been a matter of ice, heat, aspirin, physical therapy, what have you. This was reality that, okay, you've done it this time. This time it's reality.
Prior to surgery, Dr. Green makes 3 marks on the knee where 3 small holes will be made. The arthroscope is inserted into one of the portals.
You can see where our inflow cannula is coming in right there. There it is, right there.
Another portal is used for a cannula to keep a saline solution flowing through the knee, which improves visibility and maneuverability of the instruments. The third portal is for the working tools.
And the shin bone below, and in between right here is the meniscus. The first step of a meniscectomy is a diagnostic knee arthroscopy. So we'll fill the knee up with fluid and look through the entire knee to see if there's some other conditions that we can help at the same time as the meniscus tear. A little bit of fraying here along the edge of the cartilage. I use a little metallic probe to push, pull, touch various parts of the knee to examine them a little bit more thoroughly. We're looking at the outer side of this knee. The outer side of his meniscus also looks just a little raggedy there, as if maybe meniscofemoral ligament's been torn off of that. I think we'll trim that up a little bit too. Use one of our biters. The injured meniscus can be trimmed down in several different ways. In this case, I used an arthroscopic biter and a motorized shaver to remove the torn meniscus. The shaver sucks in loose tissue and then cuts it off with a spinning blade. So it is helpful for some types of meniscus tears. And that's our goal with this meniscus removal, is to make the edges nice and smooth so there'll be less of a chance of another meniscus tear. I think we're going to be finished then.
Dr. Green successfully completed Adam's surgery in 40 minutes. He believes Adam will be back on the tennis court on schedule.
He said that we got it all cleaned up. He said there was a little bit more wear and tear behind the kneecap than what we had anticipated. Once he got in there, he said that there was, there was quite obvious signs of 42 years of athletic competition in there. So he cleaned up what needed to be done. But he said there was really no complications and nothing unexpected. The MRI was pretty revealing. They knew what to expect.
Post-surgical rehabilitation varies depending on the type of injury and the specific surgical procedure. In general, meniscus surgery is followed by a period of rest, walking, and selected exercises.
After surgery, our goals are to get the motion back, get rid of the swelling, and build the strength back in the knee. Therapists will assist patients in learning how to do range of motion and strengthening exercises. They'll teach them, remind them how to walk with a normal gait without limping.
Everybody here has something that they want to get back to, and so it's my job to really understand what's important to them, what their goals are, and really match the therapy to what they want to get back to doing.
Post-surgery rehabilitation begins with gentle toning exercises such as straight leg raises, balancing exercises, and cycling to restore range of motion and build up the muscle around the knee.
Well, the knee joint has a couple of different muscles acting on it. Your quadriceps, or your thigh muscle, and your hamstrings are key in helping extend and flex the knee. And your calf muscle, which is something people don't think about, actually extends across the knee as well. So we know that by maintaining proper flexibility and proper strength and balance in all those different muscles around the knee, you can hopefully prevent subsequent injury.
Following arthroscopic meniscectomy, many patients return to about 80% of full function in 6 weeks. Adam had a quicker timetable in mind.
I had some unrealistic self-determined expectations that I would be up walking again in just a matter of days. I'd be jogging again, within 2 weeks, and I'd be out playing some singles matches on the tennis court within 3 weeks.
Adam spent the first 6 days on crutches because it was too painful to bear his full weight on his leg. But once he cast the crutches aside, he began working with Susanne on a series of Phase 1 exercises aimed to increase his range of motion and balance.
At first, just to get the flexibility back, it was just a lot of plain and simple riding the exercise bike, trying to get flexibility back into the knee. And riding the exercise bike every single day, 30 to 60 minutes a day, as much as I could tolerate.
The final 2 stages of rehabilitation focus on increasing strength and then returning the patient to their activities.
And be a little bit lighter in the landing. In the later phases, we really start pushing the strength. So we're pushing the strength and we start working on their agility, their coordination, and return to activity. So return to running, return to sports. So in the case of Adam, where he was a tennis player, the later phases are really more geared towards the jumping, the twisting, the more dynamic cutting types of things that you need when you're playing tennis.
We are fortunate to have a big team here at the University of Washington, including primary care doctors who are skilled at making the diagnosis of meniscus tears as well as doing non-operative treatment. We also work with a group of therapists who take good care of patients and help them return to their desired level of activity with an exercise program.
When we tailor a program for the meniscus, how much of that can be done at home is a large portion of it. What we're really doing each week when somebody comes in, and they usually only have to come in about 1 time a week, is that we're monitoring their progress. We're looking for, signs and symptoms. We're looking at how well they're doing the exercise, if they're doing it correctly, and whether they're ready to go on to the next level.
Adam spent 2.5 months in rehabilitation, developing a deep respect for physical therapists.
Anything I presented to her, hey, this is a new ache, this is a new pain, this is a new challenge I'm coming across. She obviously had seen it many times before and had 10 exercises to work through that issue.
Bend straight down to about 60 degrees of knee flexion. I am so thrilled to be in this profession, and I heard that PTs next to ministers have the highest job satisfaction, and I believe it. And why I get a lot of satisfaction is I get to see people progress. You see when they light up and their confidence is building, and when they get to return and they see that, yeah, this body's an amazing thing, it can heal. So I love it. I love what I do.
It's 0-0. It's a new game.
Adam is back to playing competitive tennis. He can play with his kids, climb stairs, and continue to be the extremely active person he was before his injury. For that, he's thankful to his medical team.
Good return. First rate. I mean, truly. These are people that, as I said, they understand. They understand sports injuries. They understand the challenges that somebody who's used to competing and is used to pushing the envelope. They understand where these people are coming from, and they knew when to pull back, and they seem to know when to push. All right, that's how you keep it in. Nice job.
We see a variety of different athletes of different ages and skill, whether it's high-level competitive sports in college or just simple recreational activities for a weekend warrior. Everybody wants to get back to doing the things that they enjoy and were doing prior to the injury. And our team is really focused on helping them get back to the things that they want to do.
For more information, to make an appointment, or to refer a patient, contact the University of Washington Sports Medicine Clinic at 206-543-1552, or contact the Bone and Joint Surgery Center at the University of Washington Medical Center at 206-598-4288, or go to www.orthop.washington.edu.